Hey guys, Miss Hill again, and we are going to finish up individual module 5.2, PowerPoint 2. This is lecture number 3, and I hope to be able to get through all of the alterations that can happen during intrapartum care. We're going to be talking about high-risk populations and intrapartum complications. I've been talking for so long, I'm getting tongue-tied, so bear with me. All right, so when we think about alterations during intrapartum care, it's important to note that most births, most labor and delivery will actually occur without any type of operative intervention, whether it be from a vaginal delivery standpoint or from a C-section. So the majority of births are going to happen just perfectly fine without any needed intervention or because of an alteration. But, however, there are some procedures that might be needed to maintain the safety of the mom and the baby. And remember, our goal in this class throughout the entire time that we're talking about obstetrics is healthy mom and healthy baby. Women are usually aware of the possible need for these things, but if it happens, they might feel very disappointed, they might be angry, or they might feel guilty about it. So remember me talking about their birth fantasies and how they expect things to go. Well, when we have to intervene with some type of procedure because there's an alteration, they tend to feel very disappointed. So it's important we can coach them through that. Even though they know that it's a possibility these things might happen, they still take it upon themselves and can feel guilty about it or upset. So the nurse has to provide information about any types of procedures that could occur throughout their labor and delivery process. And it's important to do that up front during the latent phase whenever they can actually listen to you. So what's happening, what are the different things that she might experience if we're at the point where we're having to make that decision right then. What is the proposal? What are the benefits of using the procedure? What are the risks of it? And are there any alternatives that can be used? And so this is a conversation that would be had with the patient and the physician or whoever was providing care. And we're going to talk about a few of these. So cervical ripening is an alteration. This means the induction of labor by helping to ripen the cervix. So we've talked about a couple of medications that help us do cervical ripening, and that is Cytotec or Cervidil. And when the cervix is unfavorable, it does not want to dilate or opposed to. It might even still be kind of firm and not even softened up enough. So cervical ripening helps prepare the cervix for that. So misoprostol is the other name for Cytotec. And basically it's a prostaglandin, just like Cervidil. The difference between the two is that Cytotec is a pill and Cervidil is actually a long string that's soaked with medication. So Cervidil, if there's a problem, but Cytotec we cannot because it dissolves. Then we all have mechanical methods as well, like the balloon catheter that we talked about, and that just helps to encourage dilation. You just stick it into the cervical opening and blow it up. Nursing care during cervical ripening is monitoring the vital signs, getting a line for what those are, and then continually monitoring them throughout the cervical ripening process, and then assessing the fetus for at least 20 minutes, and really probably continually if we have inserted something, especially something like Cytotec. These people are probably in an acute care facility going to be on the woman who is having a balloon catheter, so a mechanical method of opening, she does not need continuous fetal monitoring, but that probably is going to be sort of painful for her. So you would want to keep an eye on her pain level. Labor induction is another alteration that might have to occur in the intrapartum period. And basically, labor induction is just the stimulation of uterine contractions before labor has become spontaneous. Um, it can happen with or without rupturing the membranes. And the purpose of induction is to actually cause a birth. Before induction is attempted, though, you have to do a thorough assessment to make sure that, number one, the cervix is ripe enough that it's going to accept the induction. You got to make sure that the mom is on board, that the baby is also, the fetal heart rate is also looking okay, and that both of them are ready for the onset of labor. So evaluating fetal maturity. Is the baby old enough? Is she far along enough in her pregnancy that a delivery of the fetus at this point, this gestation, will be beneficial? And again, is her cervix ready? Is it ripened? And many times the answer to that question is no, the cervix is not ready, but we've scheduled somebody for a labor induction anyway, and that's okay, because we can still utilize the cervical ripening method and then add the labor induction method at a later point in the day, or we sometimes we can do it at the same time. It just depends on the patient. So we can actually ripen the cervix first or overnight and then start the induction in the morning. And it depends on the physician as to how they like to do that, or the hospital's protocol. But those two things can definitely be used together. Some reasons that we might decide to do a labor induction would be moms who have some diabetes, renal disease, they've got preeclampsia that's headed towards eclampsia, or they are experiencing eclampsia. Maybe they've got some pulmonary disease, they've had premature rupture of membranes, and we're worried about infection. There's some type of chorioamnionitis, which is an infection of the chorion and the amnion lining, that can affect the baby. Maybe the mom is post-term, so she's going longer than 42 weeks, and we know that the survival of the placenta is not supposed to last beyond that point. So allowing a mom to go longer than 42 weeks is dangerous for not just the baby, but for her too. Patients who have mild abruptions. Notice that word mild, and I'm talking very mild. So we have just a small, teeny tiny little spot that the placenta has separated from the uterus. And if you were going to induce somebody with a mild abruption, you would continuously monitor that baby. You would continuously monitor mom's vital signs and be by her side. You would continually be palpating her belly. And if the baby had any indication whatsoever that it was not tolerating those contractions, that patient would have a C-section. Because typically in an abruption scenario, those individuals have C-sections anyway. Intrauterine fetal demise, which means that the baby has died inside of mom. Those people sometimes will need a labor induction because they will not go into labor by themselves. Babies that have intrauterine growth restriction, or IUGR, so they've not grown appropriately and they are smaller than we expect them to be. We might need to go ahead and get those individuals delivered instead of allowing them to continue on in pregnancy. Because if babies have intrauterine growth restriction, that means they're not getting something from the placenta that they need nutritionally. So moms who are smokers, moms who have preeclampsia, all those types of issues in the maternal health can affect growth in the baby and cause IUGR. Moms with isoimmunization problems, or babies with oligohydramnios. Those individuals might be candidates for labor induction. The non-reassuring fetal status and non-reassuring antepartum testing, this one is listed in your book, but I don't particularly like it listed here because, the thought is that if you're going to induce labor on someone, that you want to make sure the fetus will be able to tolerate it. And if the baby is already looking bad, um, and it depends how bad. But if the baby's looking really bad, then we would never induce somebody with a non-reassuring status if it was terrible. We would do a C-section. But there are situations where the fetal heart rate status might be mildly non-reassuring, but we would watch those people extremely closely. Again, continuous fetal heart rate monitoring throughout this process. People who we would not perform labor induction on would be those individuals who obviously refuse to have it done, individuals who have a placenta previa, babies that are in a transverse lie, people who've had a classical uterine incision because of the potential for uterine rupture, people with an active genital herpes infection, umbilical cord prolapse, or moms who have cephalopelvic disproportion. That is absolute. So we know a baby's not going to fit through there. Those would all be contraindications to inducing labor. We would never induce labor on an individual if we know for a fact that they cannot deliver vaginally. A baby in a transverse lie is not going to come through the pelvis. And then on the flip side of that, what if you have a baby who is extremely big? So a macrosomia baby. You've seen that on ultrasound a couple of weeks ago, and the physician sends that patient in for induction. Well, maybe he hasn't seen the ultrasound report yet. That would definitely be questionable. So if there's ever a question as to whether or not the baby can be born vaginally and it's safe for the baby and the mom, then you'd always question a labor induction order. For any of those reasons. Active genital herpes infection, we would never birth a baby through a vaginal canal that has active herpes infection or an active outbreak. If the umbilical cord has prolapsed into the vaginal canal, there's no possible way to deliver that baby through the vaginal canal without asphyxiating the fetus, because you're going to, at some point, as the fetus descends, you're going to cut off the oxygenation and the blood flow that's moving through that cord. So if the cord is prolapsed, we know vaginal delivery is not going to happen, so we would never induce that person. Management of maternal exhaustion and poor pushing happens through forceps delivery and vacuum extraction. We talked a little bit about that in the previous lecture. And there are certain requirements that have to happen before you apply either of those devices. And there are advantages and disadvantages to both. So on the left side of the picture, you see forceps. Forceps can be dangerous because they can cause hematomas. They can cause the fetal skull to be crushed if they're not applied appropriately. They can cause all sorts of internal damage to the maternal reproductive structures if they're not used appropriately. But the advantages are that the physician can actually use some traction to help the mom during the second stage when she is pushing, if she's exhausted or if her pushing efforts are not effective to be able to expel the baby. The physician can have some control over that expulsion. The vacuum extraction, on the other hand, is a much safer option. And it's just a little suction cup, and it's placed right over the baby's head. Preferably not, it should not be placed on top of a fontanelle because as it's pumped up, it applies severe suction to the baby's head, so that the physician can pull and help ease that baby down through the birth canal. Um, it can cause hematomas on the baby's head. It could cause neurological injuries, potentially, if it was placed over a fontanelle. Um, and it can also cause some internal damage to the mom if the physician isn't careful about how he uses the instrument, or about how forcefully he pulls the baby down through the birth canal. So it's something that's done gently. Um, what else do I want to tell you guys about vacuum extraction? Pop-offs. So because it's a suction mechanism, as the physician pulls, the potential for that to pop off of the baby's head is there. So if there is a pop-off as the physician is pulling, as the mom pushes, that's something that the nurse would document. And if there's more than 3 pop-offs, the advanced care provider is not supposed to reapply it and try again. And I've sort of talked through some of this, but for the forceps-assisted birth, indications that the care provider might need to use forceps would be for somebody who's a nullipara, so they never had a baby before. They might not understand how pushing works. They may not be able to feel how to push. Maybe their pelvis hasn't separated appropriately, and the tissues haven't softened up. Things down there are much more tight than they would be in a multipara. So things aren't expanding maybe like they should. So that could increase the need for the use of forceps in those individuals. Maternal age, so 35 and over, they're also at risk. Short people are at risk because they're at risk for cephalopelvic disproportion. People who are who've had too much weight gain during pregnancy, obese individuals are at a greater risk for forceps-assisted birth. Individuals who are post-date, and in this case 41 weeks or more. Epidural anesthesia, because it decreases could potentially decrease their sensation of pressure and ability to bear down. If there's a baby who's presenting in a manner that's other than occipito anterior, remember we said anterior is good, that's what we want to see. But if the baby is in a posterior position, it makes it much harder for that baby to go through the mechanisms of labor and come through the pelvis appropriately. So sometimes assisting with forceps is an alteration that has to occur. Dystocia. Dystocia just means it's kind of like a troubled labor. So either the contractions aren't strong enough to work with the push to help the baby descend through the birth canal. So they need a little help from the care provider. And the presence of a midline episiotomy. If the physician has cut an episiotomy and that still is not helping the baby move down and through the birth canal appropriately, then use of forceps might be an indication, might be a needed indication. And then also an abnormal fetal heart rate tracing. So if you are going through labor and through the second stage of labor with your patient and you're noticing that the fetal heart rate tracing is becoming abnormal, that things are looking non-reassuring due to all the pushing and stress that is happening to the baby as it's coming through the birth canal, a quicker delivery might be necessary, so the physician may opt to use forceps. There are some risks. So for the newborn, you can see small areas of ecchymosis around the face. You can see edema. Cephalohematomas are possible. And then because of hematomas, Once the baby is born, if the hematomas are large enough and severe enough, we can also see hyperbilirubinemia in those babies afterwards. Bilirubin is a byproduct of red blood cell breakdown. So if the patient has a cephalohematoma and the body is working to break down all those red blood cells in that spot, and then there's going to be all this bilirubin that's released into the bloodstream, and it's going to cause the baby to have hyperbilirubinemia. And you're going to start to see sort of jaundice, possibly some jaundice. So their face will start to look a little yellow, and we'll have to do some additional interventions for that kind of baby. Sometimes, sometimes forceps can cause facial paralysis because it presses a nerve in a certain spot. That can be transient or it can be permanent. It can cause low APGAR scores. It can cause retinal hemorrhage in the babies, corneal abrasions, different types of eye trauma. And then again, elevated bilirubin levels if we have got areas of ecchymosis or hematomas that are having to be broken down. From the mother's standpoint, really, mainly we're looking at injuries to the birth canal and possibly the urethra, the perineum. If the mother already had an episiotomy, using forceps could actually cause that episiotomy to be extended or be even more, it could actually extend all the way into the anus, and that would be pretty terrible. These people can have sexual problems in the postpartum period because of pain and scar tissue. They might experience some incontinence issues and possibly some increased infections. Vacuum extraction, like we talked about, is just the application of this little suction cup to the fetal head. It is placed on the occiput. It should never be placed over a fontanelle. The longer the duration of the use of a vacuum extractor, the more likely the newborn is to have some type of scalp injury or hematoma. And like I said earlier, if there are more than 3 pop-offs, then the care provider should discontinue use. And as the nurse, it is your responsibility to keep up with those pop-offs and let the physician know or the care provider know when they have reached 3 pop-offs, because sometimes they may not remember. A common indication to use vacuum extraction is if the mom is having a prolonged second stage of labor or there's a non-reassuring fetal heart rate tracing during the second stage and we need things to progress more quickly. We prefer using the Kiwi. Kiwi is a brand name of vacuum extraction, so if I say Kiwi, I'm talking about a vacuum extractor. That's preferred to using forceps because especially in cases of where the physician suspects there might be some cephalopelvic disproportion, because you can see forceps are much larger than a vacuum extractor in the picture prior to the slide. So someone who has some cephalopelvic disproportion issues, it's going to be much harder to place forceps appropriately and use those effectively without injury, as opposed to a Kiwi or a vacuum extractor. Contraindications to vacuum extraction would be a patient who has true cephalopelvic disproportion. So we know without a doubt that the baby is not going to come through that pelvis. That patient would need to go for a C-section. Non-vertex presentations, so we have either a transverse lie or we have a breech presentation. If we suspect that the mom or the baby have some type of coagulation problems, we wouldn't want to use the vacuum extractor, because if if they had some kind of coagulation deficit so that they're not going to be able to clot effectively and we cause a hematoma on the occiput of the fetal head, or we cause a vaginal or a cervical tear in the mom, they're going to bleed, they're going to hemorrhage. If we have a baby that we know or suspect to be a hydrocephalic baby, we would not use a vacuum extractor for those individuals, or if there's some type of fetal scalp trauma that we're aware of, we would never place a vacuum extractor over that trauma, um, or even contribute to extending some type of trauma that might already be there. Episiotomy is another alteration that can occur. That's a surgical incision that happens on the perinatal body, and it helps to enlarge the introitus, or the outlet of the vaginal canal. Although it's thought to decrease the lacerations that could occur to the perineum if overstretching occurs. Sometimes a laceration happens alongside an episiotomy anyway. It may actually increase the risk for fourth degree lacerations if that happens. The woman is more likely to have anal sphincter tears, and perineal lacerations actually will heal more quickly than deep perineal tears. So the thought is that I want to say this appropriately. The thought of some minds is that it's better to let the mom have a laceration than to cut an episiotomy and then she have a laceration. Because typically, if that happens, it's much worse than just possibly having the laceration. There's a greater incidence of major perineal trauma if a midline episiotomy is done. When I say midline episiotomy, that means they just cut straight down the perineum. There are different types of episiotomies that can happen. There can be midline ones or mediolateral ones, and a mediolateral one is sort of cut off to one side and not straight down. ACOG actually discourages the use of an episiotomy when it's not indicated because of the additional trauma that can happen. There can be some preventative measures that help reduce lacerations and episiotomies, and patients can be educated on these during the prenatal period or the antepartum period. Perineal massage can help. Natural pushing during labor, and avoiding the lithotomy position. So typically in the acute care setting, we tend to put people in the lithotomy position to push, but actually if they can get in a natural position to push for their body, it will actually reduce the chance that they will tear or have to have an episiotomy. So a natural pushing position would be squatting. Sideline position for pushing will also help decrease the possibility of a laceration or episiotomy. Warm or hot compresses on the perineum can help, and encouraging a gradual expulsion of the baby at the time of birth instead of just it literally just popping out, but the care provider actually controlling those mechanisms of labor and the descent and how the baby is expelled. Because most of the time that's when tearing will occur. There are two types, like I said, there's a midline and a mediolateral, and they're usually done with regional or local anesthesia. If the patient has an epidural, you can cut an episiotomy with no problem. But if they do not and they're having natural labor, then using a local anesthetic such as lidocaine is the right thing to do. If it's an emergency situation, it is possible that the care provider will actually cut one without anesthesia. Repairing an episiotomy happens after the birth of the baby. It happens usually between the birth of the baby and the delivery of the placenta, um, or after the expulsion of the placenta. In my experience, I've seen them repaired typically after the placenta is delivered because it's such a short time frame. And if the patient has an episiotomy, again, there's no need for local anesthesia, but if she does not, they may have to numb that area up some more before stitching it. Dystocia is a dysfunctional labor. It is difficult or abnormal labor that occurs because of a problem with one of the critical factors of labor. So one of the 5 P's is out of whack and is causing a problem with the labor process. So that's what dystocia means. It can be caused by a number of different issues related to any one of the 5 P's. And risk factors for people who have dystocia are those individuals who are short, they're overweight, advanced to maternal age, they have uterine abnormalities, or inappropriate timing of anesthesia and pain meds by the nurse. So it's important. That's another reason why it's very important for you to time your interventions when it comes to pain control, because you can actually cause, as a nurse, dystocia to occur in your patient. Signs and symptoms of dystocia have to do with lack of progress in the cervix as far as dilation and effacement, or in terms of fetal descent, and they can also be due to ineffective pushing or the patient not having the urge to bear down. Management of dystocia happens from a nursing standpoint by either we might have to utilize a fetal scalp electrode or an intrauterine pressure catheter so that we can really keep a close eye on the labor pattern and what it is actually doing. We might have to artificially rupture the membranes or do an amniotomy. Making sure that the patient's bladder is not distended. So encouraging voiding, encouraging position changes, because if the fetus is in a posterior position, utilizing position changes to hopefully make it turn into an anterior position could help dystocia. Assisting with relaxation, because patients who are very tense actually will hinder the labor process and the process of contractions. So helping your patient to relax can actually contribute to helping dystocia be not as severe or even go away completely. Effective coaching by the nurse during the second stage, and then continual fetal heart rate assessment. Sometimes we have to administer pain medications to help with dystocia, so starting them on some Pitocin to help those contractions, or giving them some pain medications to encourage that relaxation if they can't do it on their own. Dystocia related to contractions come in a couple of different forms. We can talk about hypotonic contractions, which means that they are not doing what they are supposed to because they are not strong enough. They're ineffective. Typically, they occur in the active phase. They're painless, and we have to augment those with something like Pitocin. We want to monitor their progress when it comes to hypotonic contraction, and sedating them, meaning giving some type of narcotic to help them relax, does not help whenever dystocia is related to hypotonic contractions. On the other hand, we have also dystocia that can be related to hypertonic contractions. These are also ineffective, but typically we see these in the latent phase of the first stage. They are painful for the patient, um, and our goal is to slow those down. They're coming too fast, and they're not allowing enough resting tone in the uterus. So we have to slow down the hypertonic contractions. We monitor progress for the patient, and sedating them with hypertonic contractions is helpful because it allows the mom to be able to relax and the body to sort of just do its thing. If the patient is on some type of Pitocin and you're noticing hypertonic contractions, you would stop that medication because the goal, again, is to slow things down. There are some unfavorable outcomes related to dystocia. So the pathologic retraction ring or Bandel's ring that we talked about in the earlier lecture can occur. And again, that is just a constriction ring that happens between the upper and the lower uterine segment due to dystocia, and it will sort of trap the baby in there. Um, Precipitate labor is also an unfavorable outcome. So if you have some hypertonic contractions that you can't get slowed down, then it can cause the labor to occur very quickly. A precipitate labor happens in less than 3 hours from the onset of labor to the birth of the baby, and that can be traumatic on the maternal reproductive system, the vaginal canal, the cervix, because things move so fast. It can also cause bruising in the fetus because of the quickness of the process. Uterine rupture is also an unfavorable outcome. So if we have a patient with those hypertonic contractions and we cannot get those slowed down, it puts her at a greater risk for uterine rupture if we cannot effectively implement some type of intervention that will allow her to have some good resting tone. Uterine inversion is also something that can happen due to dystocia, and uterine inversion is when the uterus basically turns inside out. So after the birth of the baby, it just turns inside out, and that's can be a bad thing and put the mom at risk for hemorrhage. Postpartum hemorrhage, on the other hand, if you have somebody who's had hypotonic contractions throughout their labor process, that tells you that their uterus is not contracting like it should, right? So if it's not contracting like it should during labor, then chances are it won't contract like it should after labor. And if we're talking about things from a hypotonic standpoint, so it just doesn't want to contract at all, now we've increased the risk for the patient to have a postpartum hemorrhage because the uterus doesn't want to contract or is hypotonic or experiencing some type of atony. Amniotic fluid embolism can also be an unfavorable outcome of dystocia, and non-reassuring fetal heart rate tracings, depending on what you have going on. There are some different intrapartum high risk factors that we like to be aware of as well. Intrapartum high risk factors are physical and mental conditions that increase the chances of something else to occur during the process of labor and birth. So we have a situation that could compound itself, basically. It could be a maternal factor or a fetal factor, but overall it's going to jeopardize the safety and the well-being of both the mom and the baby. Intrapartum high-risk factors can be coexisting with the intrapartum period, or they can occur before the onset of labor. They have to be managed and they have to be monitored much more intensely. Sometimes we have to expedite the delivery for a positive outcome, and they can result in injury or morbidity and mortality for the mom and the fetus, and they can also cause emotional distress for the parties that you're taking care of. So what are they? Uh, Chronic medical illnesses are included in this category, so things like cardiovascular disease, asthma, renal problems, urinary tract infections, autoimmune disorders, STDs, hypertensive disorders, anemia, seizure activity. I mean, there's just you can't even name them all, but anything that's a chronic medical illness, a chronic medical illness, can put the patient at being high risk in the intrapartum period. Past surgical procedures, if the patient has had some type of uterine surgery in the past, that makes her high risk. Patients that are post-term in their pregnancy, individuals that have an intrauterine fetal demise, they're more at risk for infection. Preterm labor, individuals that are having some dysfunctional labor or dystocia. So they may have a failure to progress through the labor process. The cervix doesn't dilate or efface. They're experiencing hypertonic or hypotonic contractions, or there's some type of precipitous birth. Individuals with placenta previas or abruptions or histories of abruptions, inadequate pelvic measurements or cephalopelvic disproportion, individuals with low socioeconomic status, different cultural beliefs and practices, individuals with a history of uterine rupture, or who are at risk for uterine rupture. All of these things make people throw people over into a high risk category whenever you're the labor nurse. Infections can also put a mom at being high risk because of the transmission to the newborn, or because of the effects of that infection on her as well. Individuals who are substance abusers, and they puts them at high risk due to maternal withdrawal, because she's not having access in the hospital. Also, those babies typically will be IUGR or growth restricted. They might be preterm even. Those individuals that abuse substances are at a greater risk for abruptions. And the list continues to go on and on. People who have minimal or no prenatal care because we don't know what's going on with them, that makes them high risk. If it's an unwanted pregnancy because she may not have taken care of herself. Individuals with mental illnesses or who have psychosocial issues like partner abuse or PTSD, that makes those people high risk patients. Patients who've come in with some type of trauma from a motor vehicle accident or from intimate partner abuse, individuals that are obese or malnourished, amniotic fluid embolisms, people who've been exposed to teratogens can affect the outcome of the fetus. And again, the list just goes on and on. We've talked about the majority of these things. And so really what you should do is move through each of these bullets on your own and try to determine why does that put the patient at high risk? If the patient is coming in for delivery, how does this particular thing affect my patient? So let's do one together, such as let's do retained placenta. If the individual has a retained placenta, she might have not been high risk prior to that during the intrapartum period, but now she has a retained placenta. So that's thrown her over into a high risk category, and she needs your focus as the nurse. If she has a retained placenta, she's going to be at a greater risk for infection. She's going to be at a greater risk for postpartum hemorrhage. She might possibly need to go down to the OR for surgery, so she might need some additional medications. Her family's going to need to be informed. You're going to need to educate her about what this means. And then after the retained placenta is removed, you might have to, you're going to have to monitor her continuously for possible postpartum hemorrhage. You're going to have to monitor her vital signs. It will change the way you take care of her. And let's see. Let's do one from a fetal standpoint. So a high risk factor from a fetal standpoint would be macrosomia. If the baby is really big in utero, it sometimes will stretch the mom's uterus to the point that doesn't allow it to want to contract after delivery. So it causes some uterine atony or puts her at risk for that. So anybody who has a baby that's a macrosomia baby puts the mom at higher risk for postpartum hemorrhage. So again, with that mom, you're going to be paying really close attention to your lochia assessments and your fundal rubs, and you might have to be massaging when it's boggy. So depending on those high risk factors will depend on how it will affect the outcome. Who is it going to affect, the mom or the baby? Is it going to affect them both? And how are you going to change your assessment and your intervention for that patient related to that high risk factor? For lifespan considerations, when we talk about the intrapartum period, we're going to still focus on those two categories that we focused on um, throughout class, and we're going to be talking about the adolescents and the people over 35. So for adolescents, sometimes they don't have good prenatal care because they're afraid to tell people. They don't go get care because they don't know how to. Maybe they don't even know they're pregnant. So they're automatically in a high risk category. Um, they are also at risk for pregnancy and labor complications. So we have to be especially alert with these individuals. Remember that adolescents are not finished growing, so their pelvic structures may not be yet mature enough to they may not be ready for a vaginal delivery. These people are at a greater risk to have a C-section. What's their support system? Do they have a good one, or are there people not there? Are people mad? Maybe the people are there, but it's so tense because her parents are angry or her caregivers are angry that she's in this situation. So being nurturing and being making yourself available for a trusting relationship with an adolescent is key, because you're going to need her to trust you enough that she will listen to your education, that she will trust you enough to communicate with you effectively, and that you can really get a good assessment of whether or not she's prepared to take this baby home. Um, Very young adolescents are going to have much fewer coping mechanisms and less experience to draw on than older adolescents. So your 13-year-old is going to react to the labor and delivery process much differently than the 18-year-old will. And these people have an incomplete cognitive development, so they don't have any problem solving capabilities like a grown-up does. They are very quick to make decisions. They don't think about the consequences of the decisions that they make, and their underdeveloped cognitive level puts them at a higher risk during the labor and delivery period, because, I mean, you may tell them to not get up out of bed and go to the bathroom. You may tell them, if you have to have a bowel movement or feel like you have to have a bowel movement, call me. Don't get up on your own. But some adolescents might not have the cognitive development to realize that you weren't just telling them not to get up because you didn't want them to, but you didn't want them to get up and have the baby in the toilet. So you have to be very specific about your education with these people too during labor. Again, they're more childlike and they're very dependent on you. They're going to experience pain in a much more different way, depending on whether, all of your care has to be so individualized. You can't lump things into one bucket. So touching, soothing encouragement, and comfort measures, that's going to be different for everybody. If this was an adolescent who was raped and is now pregnant, she probably is not going to want you touching her. Um, so you have to be familiar with the situation they're in, and sometimes you have to just ask them if it's okay. Um, they're probably going to ask you questions and seek information, so be honest with them, particularly when it comes to pain. If this is a patient who's going to be giving up her newborn, you should give her the option to see that baby and to hold that baby because it helps facilitate the grieving process. And some people who are giving up their children will tell you that they do not want to see them, they don't want to hold them. But research shows that if they do, it helps them move through that grieving process appropriately. So if they tell you they don't want to, you should encourage them to and continue to talk to them about it and try to change their minds. And you might not, but you should try. Adolescents also have to have really individualized postpartum care because of psychosocial issues that are unique to their age group and their developmental level. You have to be certain that they know how to take care of themselves and the baby. They're at increased risk for unintended subsequent pregnancies and abortions. So, making sure that they're on some form of contraception that they're going to follow and that they're aware of the risks of getting pregnant based upon their sexual behaviors is also something that you should talk to them about. Women who are over 35 can respond to the stresses of labor very similarly to younger women, um, especially if they've never done it before. The risk of maternal death is much higher in women over 35, and it's even higher than that for women over the age of 40. And probably somewhere along the way, these individuals have heard that, so they can be even more anxious than your typical patient that comes in. They're also more likely to have chronic health conditions that will complicate their pregnancy or the labor and delivery. They have higher rates of miscarriage, stillbirth, preterm births, low weight births, perinatal morbidity, and mortality. So they're already in a high risk category when they come in. if if these individuals are physically fit and they don't have pre-existing medical conditions, that puts them at a much lower risk to have complications um, than those people who are not physically fit or have pre-existing conditions. So we're going to move into and talk about some of the different complications that we might see intrapartally. And the first thing that we're going to talk about is post dates and the post-term baby. The concern with being post dates or greater than 42 weeks is the viability of the placenta. It was an organ that is grown to only last a certain number of weeks. And past 42 weeks, it starts to not function appropriately. So the baby will lose nutrition, lose oxygenation, and it can affect the fetus. So for these people, we might need to induce labor because for whatever reason, their body just hasn't decided to do that yet. However, before we induce labor, remember the eligibility requirements for that. The baby has to be head down. We have to have a term pregnancy, and if we're post-term, we definitely meet that. Bishop score is something that tests cervical ripening. It is a you give a number to the cervix whenever you do a vaginal exam that gives you a Bishop score. And but basically what it means is it's testing to see whether or not the cervix is ripe enough. Is the cervix ideal to induce labor? Is there an urgent need for these people to deliver? And do they have any type of cephalopelvic disproportion? All things that have to be considered and pass eligibility requirements before proceeding with induction. We've talked about some different types of ways that we induce people, but from an IV standpoint, we typically put these people on a Pitocin IV drip. It's It is mainlined. It's piggybacked into the main line of the IV, but it is piggybacked into the lowest port on the IV. So down towards the hand or wherever your IV is. It's not piggybacked into the tubing at the top of the pump. Because if we have to stop Pitocin or discontinue it because of a problem, we want to be able to stop it as quickly as possible. And if we have piggybacked it into the main line way up high, then there's Pitocin left in all of that line that has to infuse into the patient. So we always piggyback it into the lowest port on the main line. Sometimes we can rupture membranes. That's a sterile procedure, and it's done by the advanced care provider. And then if the Bishop score is not ideal, we can do some cervical ripening agents along with Pitocin or even artificial rupture of membranes. And then if we're inducing somebody, continuous electronic fetal monitoring is required. You can see in this picture that this baby has some peely and kind of scaly looking feet. So this is your post-term baby. And these babies can be large, but they can be malnourished because if the placenta, they have grown and grown and grown, and if the placenta then starts to become less viable and less able to get nutrients and oxygenation across to the baby, then you're going to see signs of malnourishment. So they may be big, but they may be skinny. Preterm labor is another one that is an alteration. Let's go back a second. I have something else I want to mention here. If the baby is very large or a macrosomic baby for a post-date individual, the nurse should really be very cautious and even question the Pitocin induction because of the possibility that there may be some type of cephalopelvic disproportion that could occur, or there could be some kind of passenger relationship issue if the baby is very big. So you always want to be aware of the size of your fetus as well. So from a preterm labor standpoint, that's the onset of true labor from 20 to 36 weeks gestation. A major cause of preterm labor, there are a bunch of them, but infection, a history of preterm labor, multiple pregnancies, different types of obstetrical procedures that can irritate the uterus, so amniocentesis, contraction stress testing, individuals with a weak or incompetent cervix. All of those are major causes, and of course there are others like drug use. But the patient will have abdominal cramps and contractions. They'll complain of a low backache, possibly abdominal pressure, or they might have a sensation of pushing down internally. They may have a change in their vaginal discharge or start to show they might have some bloody show that occurs. And we manage preterm labor usually with bed rest and hydration when we're thinking about things from a long-term standpoint. If the patient comes into the hospital and she has a urinary tract infection, then of course we're going to treat the infection and we may give her some fluids. If the patient's been out in the yard working and she's become dehydrated and that's why she's now having some preterm labor, well, doing bed rest and IV fluids hydration would probably help fix her labor. We want to minimize vaginal examination for people who are in preterm labor because we don't want to stimulate the cervix or irritate things any more than they already are irritated. So we don't do sterile vaginal exams on these individuals as frequently as possibly we would for someone else who's in the intrapartum period. We always want to identify the type of organism that the patient is infected with if that's what we believe is causing the preterm labor, because we want to treat that in order to stop the labor. Administering tocolytic agents which are drugs that will help stop contractions. And our main ones for that are terbutaline, nifedipine, mag sulfate, and indocin sometimes is used as well. Remember, our first line medications are the breathine or the terbutaline. And our second line medications are things like magnesium, if we're talking about management from an acute care standing. Now, sometimes we can use a first line tocolytic like breathine, slow things down, stop it, or slow it down enough that we can put the mom on Procardia or nifedipine and then send her home on that to maintain that status. And sometimes she doesn't need anything at all. If we believe that the patient is going to deliver or we're not going to be able to stop this preterm labor, we would give a corticosteroid to her. We do that intramuscularly, and the typical dose is somewhere between 12 and 24 milligrams. We give that to enhance maturation of the fetal lungs, so that if the fetus is born early, the chances of lung problems are lessened. Uterine rupture is an obstetrical emergency, and you can see in this picture here that uterine rupture has occurred and the baby is now outside of the uterus. And causes of this can be from a number of different things, but an unwise use of Pitocin when inducing or augmenting somebody's labor. So we've hyperstimulated the uterus to the point there was no resting tone, the pressure built up too high and ruptured, just like a balloon that you blew up too much and it popped. It's the same concept. If people who have had previous abdominal trauma or surgeries, possible scar tissue that has ruptured, those individuals that have had a C-section with a classic incision in the uterus, those people are at definite risk for uterine rupture. People with macrosomia babies, large fetuses, so that again the uterus has gotten too big, too thin. Polyhydramnios, same concept, the uterus is too big. Version procedures, so the physician has tried to rotate the baby from an internal or an external standpoint and caused a rupture. And forceps can also rupture a uterus as well if they're not used appropriately. What you're going to see from a nursing standpoint for somebody who has a uterine rupture is a sudden cessation of contractions. There won't be any because the uterus is ruptured and now it can't contract at all. So you're going to see a total stop of uterine contractions. The fetal heart rate will show signs of immediate distress. The mother will report that something has given away. She'll say, I feel like something popped. I feel like something is given away. She'll have that sensation. You might be able to, or you will be able to palpate fetal parts through the abdomen. The abdomen will take on a different shape than it had, so it might not be as symmetrical as it was. The patient is going to start to show signs of shock. You're going to see her start to vomit. She'll show signs in her vitals of shock for like tachycardia, hypotension, tachypnea. You're going to start seeing vaginal bleeding. And again, all of these OB emergency, this patient has to have a stat C-section immediately. So you're going to be giving IV fluids, possible she'll be getting some blood at some point. We're going to do the best we can to contribute, and that baby will have to be resuscitated probably. Most of the time, uterine rupture occurs in multigravidas. That's when we see it most. And The reason for that is because multigravidas have had previous pregnancies. That's what makes them multigravidas. So their uterus has been stretched. And for somebody who has had multiple pregnancies, or even one where their uterus was stretched a lot, they can end up with something called a uterine window, and it's exactly what it sounds like it is. It's an actual window into the uterus. So the uterus becomes so thin that you can actually see through it. And it is, if the uterus has been stretched out time and time and time again, it can cause that uterine window to expand or become more obvious or more thinned out, which puts her at a greater risk for rupture when we're talking about multigravidas. Amniotic fluid embolisms are caused by a rupture in the amniotic sac or maternal uterine veins, and it's accompanied by a high intrauterine pressure that causes that amniotic fluid or whatever the contents are into the maternal circulation. So there's a pressure change from inside the uterus, and we know that things will flow from areas of high pressure to areas of low pressure. So the pressure in the uterus is very great. And if there is the ability for a little amniotic fluid, for a little bit of amniotic fluid or its contents, whatever's in it, to flow from an area of higher pressure to lower pressure, then it will do that. So that's how it ends up in the maternal circulation. Some causes of that are multiparities. So people who also have tumultuous labors, very difficult labors, a mom who's had an abruption, people who are getting Pitocin administered, large fetuses, hydramnios, fetal demise, meconium stained amniotic fluid. So we could potentially have an amniotic fluid embolism that contained meconium as well. The patient is going to complain of a sharp pain in their chest. They'll start becoming dyspneic. You'll start to see cyanosis, and cardiac arrest will ensue if we can't get a handle on things very fast. The mortality rate for amniotic fluid embolisms are very high because it happens so fast. These people have a sense of impending doom when it happens. They know that something is happening to them, and it is very, very scary. So you will see that all over their face. And what happens with this bolus is that it gets into the maternal circulation, and then it will travel somewhere that obstructs a pulmonary vessel that starts to cause all these signs and symptoms. You'll also see things like hypotension. They'll be anxious, restless. Their respirations will be labored. Again, like I said, a sense of impending doom. It can happen after delivery of the placental during the third stage of labor. So the labor nurse should always look for these signs and symptoms during the third stage and be prepared. This is an OB emergency. This patient's going to get oxygen 10 liters by mask. You're going to start running IV fluid boluses. You're going to start CPR. If the patient still has the baby inside, make sure your positioning is correct so that we're not dealing with a maternal supine hypotension syndrome situation along with the other issues. You're going to have to give this person blood probably. They'll get a Foley. You'll monitor eye and nose. You'll monitor the fetal heart rate and maternal vital signs. If the fetus is still in utero, an emergency C-section will ensue, and this person will be intubated. It's very, very scary. The other thing that we want to talk about is umbilical cord prolapse. So this happens when the umbilical cord becomes displaced and falls out prior to the presenting part of the fetus. So it starts to protrude through the cervix, and you can see that in the picture here. Membranes have to be ruptured for this to happen, and once the membranes are ruptured, sometimes with that gush of fluid out of the vaginal canal, the cord can rush out with that fluid and go below the presenting part. If the baby's presenting part is engaged in the maternal pelvis, a prolapse will not typically happen because the baby is already engaged. But this tends to happen whenever the baby is not engaged. And that's when the risks is high. So someone who had rupture of membranes but the fetal part was not engaged into the pelvis, we would never allow those people up to walk around the OB unit. We would keep them in bed. So causes are premature rupture of membranes, again, prior to engagement of the fetus. Babies who are in a transverse lie because there's nothing that's engaged into the pelvis. Babies that are small for gestational age. If their presenting part is really small, then the potential for the cord to slip through is greater than it would be in a normal infant or even a bigger infant. People who have unusually long umbilical cords, or we have multifetal pregnancies, if there's some type of cephalopelvic disproportion, a placenta previa, because the placenta is implanted closer to the cervix than what you would normally find. And then individuals that have polyhydramnios or oligohydramnios, they're also at risk for this. The result is that the presenting part will place pressure on the umbilical cord and basically asphyxiate the fetus, cut off oxygen supply. The mom will report to you that she feels something down there. You might be able to see the cord. If you do a sterile vaginal exam, you might be able to feel the cord. If you ever do a sterile vaginal exam and you feel a pulsation, like a heartbeat, that's a bad sign. Then you've got a cord prolapse. You will start to see on the monitor, on the fetal monitor, variable and prolonged decelerations. Remember that variables go along with cord compression. So you're going to see some probably very deep variables related to cord compression because of the prolapse. There will be an extreme increase in fetal activity. So you'll see some hyperactivity, and then you'll see the fetal activity cease. So it'll come and go, and that happens with the variable. If I cut your oxygen supply off, you would squirm for a little bit until you passed out, right? So it's kind of the same concept. They'll have hyperactivity, and then when the cord gets squeezed, you might see a cessation of activity, or after it, after they have oxygenation again, you won't see quite the hyperactivity. The priority with an umbilical cord prolapse is to get pressure off of the cord, and you can do this by changing their position. That is the fastest way to do it. So again, it's an OB emergency. You have to check the fetal heart rate after rupture of membranes, making sure that this patient is on bed rest. If she has ruptured membranes and the fetal presenting part is not engaged. If you notice a cord prolapse upon vaginal exam, you would relieve pressure off of the cord. So you would push the presenting part off of the umbilical cord to relieve that pressure, and you would stay that way. You would not move until the baby was born by C-section. You're gonna be calling for help. You would flip the patient over into a knee chest position, like in this picture, because gravity would help get the presenting part off of the cord, along with the pressure that you're applying. Administer oxygen and prepare them for a C-section because they're going to have one. You cannot deliver vaginally if the umbilical cord is going to be asphyxiated during the process of that. So these people will have a C-section. Hold the head off of the cord if you're able to do that, and then putting them in knee chest or Trendelenburg is the appropriate position change. This is a photograph of a baby who had some meconium, and meconium stained fluid usually, or release of meconium from the fetus in utero, usually happens in relation to fetal stress, which causes hypoxia. And that causes the baby to have a vagal nerve stimulation, which results in peristalsis of the GI tract in the fetus and relaxation of the anal sphincter. So that's the mechanics of what happens. But what we know is that when meconium happens in utero, it's in relation to some type of hypoxic event. Sometimes it can occur because of cord compression. For moms that are greater than 38 weeks gestation, they become at a higher risk every week for meconium stained amniotic fluid at a certain point. I don't know that I've ever seen anybody deliver at 42 weeks or past that did not have meconium stained fluid. And remember, we said the placenta was only meant to last for so long. So if we're getting towards post dates, then the placenta may be cutting off oxygenation to the baby. It might cause some hypoxia, and then you're going to see some meconium stained fluid. When the membranes rupture, you'll notice that the amniotic fluid it could be black, green, yellow, brown in color. It might have particulate mixed in with it. It can be thick or thin. And that's one reason why we assess the COCA of amniotic fluid upon rupture of membranes. You can verify distress when you have meconium and variable or late decelerations in the fetal heart rate tracing. If you have meconium in the amniotic fluid and you're seeing tracings on the fetal heart rate monitor that include variables or late decels, that baby is in distress. We manage this by obviously documenting what we find upon our assessment. Sometimes we can do an amnio infusion to help wash out some of that meconium from the uterus. We monitor the fetal heart rate. We treat the late and the variable decelerations with intrauterine resuscitation. We prepare the nursery staff and ourselves to deliver a baby that can potentially have a low APGAR score. We do not, and I believe that the research has changed on this, but previously we would not stimulate the infant to breathe, because what we wanted to do was we wanted to suction out the lungs. So the physician would not suction the mouth and the nose on the perineum like in a normal delivery, because we didn't want the baby to cry. The thought was if the baby cried, that it would suck the meconium farther down into the lungs. So that's why we didn't stimulate them to breathe initially, because we wanted to use the laryngoscope and use deep suction to get as much of the meconium as we could out of the lungs prior to stimulating the baby to breathe or the baby crying. I think that research has now shown that that's probably not the best practice, so things have changed a little. But if you had an infant that was born and they were not breathing, we would want to deep suction them first. We wouldn't want to bag and mask them prior to suctioning, because we don't want to force any more meconium into the lungs than is already there. These kids can end up with aspiration pneumonia, and they can actually die from this. So the meconium staining of amniotic fluid is more a fetal problem than it is a maternal one. There can also be some umbilical cord abnormalities. When a baby is born, you should always look at the cord to make sure that we have two arteries and a vein. It is possible to have a two-vessel cord and the baby survive. Um, so if you only have two vessels in a cord, though, you have to have at least one artery and one vein. A pregnancy will not survive if it doesn't have at least one of those, but typically you should see two arteries and one vein. We should note any type of unusual cord length, so any cord that is short or long, that puts the baby at risk for cord compression if it's too short. If it's too long, possibly it could cause a umbilical cord prolapse. If the cords are very long, sometimes they can get knotted up in utero as well. You don't have to worry too much about the velamentous insertion of the cord or the vasa previa, but these are pictures of those two at the bottom here, and it just means that the cord is kind of implanted into, it's got an abnormal implantation into the placenta. There can also be placental abnormalities as well that cause maternal issues post-delivery. Placenta accreta, there is one called a placenta circumvallate and placenta succinturata. I'm not even sure that I say that right, but basically what you're looking at are placentas that have implanted themselves abnormally into the uterine lining. So if you look at this picture on the far right-hand side, a precreta is one that has implanted itself completely through the uterine wall. An increta has implanted itself into the myometrium kind of midway, and an accreta has implanted itself a little farther than it should have. What I want you to know about placental abnormalities is that they put the mother at risk for postpartum hemorrhage. Also, these people are going to experience a retained placenta in the third stage of labor. Because these placentas are not going to release themselves from the uterine lining like a normally implanted placenta would. So that's really what I want you to focus on, and really not the particular names of these. If there's some type of abnormality that occurs and it's implanted too deeply, it's not going to separate appropriately. We're going to be looking at a retained placenta potentially, and this patient is going to be at risk for postpartum hemorrhage. So let's talk about the nursing process before we finish up. And patients may range from families that want maximum interaction with you to families that want to be left alone as much as possible. Your goal is to meet their needs and meet their preferences as long as you can provide safe care for the mom and the fetus. We have an increased focus on family-centered care, but the nurse has to be ready to meet the needs and the concerns of the laboring woman alone as well. You always provide high quality and individualized care is key in labor and delivery. You have to be very frequent and very accurate about your assessment of the mom and the baby, because that is crucial to having a good outcome. Making sure that you know your traditional assessment techniques and that you have the ability to utilize those techniques with other experience and use of technology to assess the patient you can't see is imperative. Nursing diagnoses can differ from stage to stage in regards to labor, and I will let you guys read through these on your own. So again, some more nursing diagnoses. From a planning standpoint, the nurse develops a general plan that encompasses the total process um, of the labor and delivery, but you also have to compartmentalize that plan for each stage of labor and birth. The overriding goal is a healthy mom and a healthy baby at the end of all of this. But additionally, you might have to include the support person or the support people that are there for your patient because, again, we're utilizing a family centered care model. We're going to offer reassurance to not just the patient, but the family and the support people. We're going to educate whoever we can that's there. We want to help promote maternal coping behaviors, and we need to acknowledge and support the mom's birthing fantasy and her desires and her choices whenever we possibly can, as long as it's not going to hinder our main goal or our overriding goal, which is healthy mom, healthy baby at the end. Creating an environment that is sensitive and supportive to the mom and the family in terms of her physical, her psychosocial, and her spiritual and cultural needs is very important. And it also helps them look back on their experience in a manner and feel empowered about the process. And it helps them also to feel, to have a positive outlook on what happened. We have to integrate their cultural beliefs whenever we are doing any types of interventions. So knowledge of their values, customs is important. And if you don't know, again, just ask. Modesty may be very important to certain groups of people, people who are extremely religious, Muslim individuals. Modesty is very important to them, and the labor and delivery process is not a very doesn't lend itself to modesty very well. So as a nurse, if you have someone like this, you got to do what you can to try to preserve their dignity and their cultural and customary beliefs. Different cultures also express the way they experience pain differently. It can vary from being turned very inward to individuals who are very vocal about it. Some people may view pain as natural, or some of them might even be angry about the intensity of the pain that they're feeling, and sometimes because of a fear of losing control. So being there to support them and knowing how they are experiencing and expressing their pain can be helpful from an implementation of intervention standpoint. Nurses have to avoid stereotyping and judging people based on their personal beliefs. So it's also important in all areas of nursing to be very self-aware of how you believe and how you feel so that you can put those things to the side and take care of your patient based on how they feel and what they believe. Nursing care on admission for laboring women. Obviously, we'll start with an assessment, an introduction, admitting them to the labor room. You'll be explaining to them how the process is going to unfold. You will be explaining the equipment and the different technology you might use. You'll start to develop a rapport and begin the assessment process with her and her family. And it's important to remember that all patients have the right to accept or reject different types of care measures. So just because it's on your order set for you to do, she still has the right to reject it. And sometimes as labor nurses, especially ones that work in acute care, that makes us feel very offended when people don't want to be on the monitor because that makes our job a little more difficult. But we have to remember that we're trying to support the patient, and we want her to feel empowered, but we also want a good outcome. Informed consent before any type of procedure involving her or even touching her baby is important. So, getting an informed consent about doing the hepatitis B vaccine on admission, that's the time to do that, not right after she's had the baby. Trying to get informed consent then. We want to get informed consent on admission. Laboring families have expectations. So these birth fantasies that we talked about, and many times they're unrealistic. So asking them about that and then trying to give them a picture of reality, um, while supporting as much of their birth fantasy as possible, can help their outlook on the experience and make things progress in a manner that is more safe for the patient and her baby. Assisting with positioning is something that you do throughout the intrapartum period and not just on admission. Effective nursing decision admission are going to include things such as, should you let the patient ambulate? Does she need to be on bed rest? Can she do both? Which one should you encourage and at what time? Do you need to be monitoring the fetal heart rate, or are we at a point that it's safe enough to allow intermittent monitoring? What are her in the birth? Does she want to be in a lithotomy position? Does she want to be side lying? Does she want to be squatting? Um, does she want her support person there or not? Special needs people typically need a support person. Auscultate the fetal heart rate, get your vital signs, assess contractions. Explain the vaginal examination procedure and let her know that you're going to have to do this throughout the labor process. If she's having signs of an advanced labor, so towards the later end of the active phase or the transition phase of the first stage, let her know. If she is being admitted at that time and you're seeing these signs of advanced labor, you're going to need to do a vaginal exam as quick as possible. Typically, we try to do the least invasive thing first and work towards the most invasive thing. But in some situations, you'll have a patient who presents who just feels like she is about to have the baby, and she may even say that to you, I'm getting ready to have this baby. For that patient, you might be able to introduce yourself and say, I need to do a vaginal exam, and that may be your first thing. So again, care is so individualized based on the scenario in obstetrics. Results of the fetal heart rate, the uterine contraction evaluation, and the vaginal exam will help the nurse determine how quickly she needs to get the rest of the admission and assessment process done. And that will also clue her in terms of different or additional interventions that might need to be required at that time, or if they can wait till later. We always collect a clean urine specimen. We test it for all the same things that we test it for antepartally. And we do any type of admission lab work, CBCs, type and cross. We do the STD testing again, all of those things we talked about in the antepartum period. And depending on how rapidly their labor is progressing, the nurse may have to notify the healthcare provider before or after completing the admission process. Because if the woman is coming in and she's going to have the baby in 15 minutes, we don't have time to do the admission assessment. We have to get our doctor there and get the patient delivered. Entering the admission note into the charting system is part of your documentation process. Many times on the floor, that can be done at the same time while you're talking to the patient, and many times in labor and delivery, it can be done as well at the bedside right then. But sometimes if you're in a crunch and the patient's going to be delivering shortly, that may have to be done at a later time after you've taken care of your patient. So again, our ultimate overriding goal is a safe delivery of the mother and the baby. But along the way, we want her to understand the labor process. We want her to maintain feelings of empowerment and control. We want them to be free from infection and injury. We want to make sure that we provide them the comfort measures that are effective at keeping pain at a tolerable level. We want to maintain hydration and make sure that we've got good acid-base balance in the fetus and the mom, and promote effective bonding at the end of all of that. Other expected outcomes that we can include also are making sure that the mother's physical, psychological, and psychological well-being are maintained and supported throughout the process, and that same thing for the baby, that we have protected and supported the baby's physical and psychological well-being. Family members, again, play an important role. They have an input into the birth process whenever we're providing this family-centered care model. So allowing them the opportunity to participate as much as they want to is important, and giving them that opportunity. The mother and the baby, obviously, having an outcome of a safe birth and being healthy at the end of all of it is, again, the overriding goal. Additionally, we're evaluating any interventions that we have implemented throughout the entire labor and delivery process to determine whether further care is needed. Do we need to change the approach of our interventions that we're implementing, or not? Are they working? If our outcomes are not being met, then we obviously will continue to revise our plan of care as needed. This is the end of Lecture 3 for Individual Module 5.2, PowerPoint 2. Thank you guys for listening. A lot of information. Thanks again.